اولا انا بشكر الاستاذ الدكتور عادل اتريبي. انا عارف ان هو شبع من الشكرانيه، لكن الحقيقه انا بحيي فيه البرسيفيرنس انه يعمل الكارديو لوكسور ديسبايت اول التحديات اللي شايفها قدامه. ربنا يوفقك دايما. This session is about heart failure update. أنا بيشرفني إني to share this session with Professor أحمد عماد الدين. مش عارف سيد فرج موجود، أو الأستاذ الدكتور سيد فرج، محب مجدي، والأستاذ الدكتور نبيل فرج. يمكن الدكتور أحمد يحب يقدم الفيرست.
إن شاء الله أول محاضرة should we give beta blocker boost MI. I am honored to introduce my dear professor Dr. طارق الزواوي, البروفيسور of cardiology Alexandria University. اتفضل دكتور.
شكرا. بسم الله الرحمن الرحيم. طبعا أنا بتوجه بالشكر يعني والتحية للأستاذ الدكتور عادل الأتريبي لنجاح المؤتمر المتميز ده social and scientific. Should we give beta blocker boost MI? يعني I hope to answer this question by the end of the presentation. Beta blockers play a role across the cardiovascular continuum, and there is a great debate in every step for the prognostic effect of heart failure, except in prognostic effect of beta blocker, except in heart failure. In heart failure, there is a solid indication and without any debate. Should we give beta blocker to improve prognosis in heart failure with stable coronary artery disease patients? This meta-analysis included more than 21,000 patients, and the primary endpoint is the cardiovascular death, non-fatal MI, and non-fatal stroke, and found that no difference between beta blocker use or no use of beta blocker in patients with stable coronary disease with previous history of myocardial infarction, stable coronary disease without myocardial infarction, and even in patients with at risk to develop coronary artery disease. So the guidelines for patients with stable coronary disease, beta blockers recommended only Class 1 recommendation to control heart rate and symptoms only and not to the prognosis. And the Class 2A, if the patient is asymptomatic and the myocardial perfusion scintigraphy proved the area of ischemic burden more than 10%. We come to patients with myocardial infarction. As we know, the use of beta blocker in myocardial infarction decreases the heart rate, decrease the contractility, so improve the ischemic chest pain, and at the same time the beta blockers stable the enhanced automaticity and decrease the ventricular fibrillation threshold, decrease the after potential, so decrease the risk of arrhythmia and sudden cardiac death. So the use of beta blocker is important to prevent mortality. However, the beta blockers therapy in the era pre-perfusion therapy differ from the era of perfusion therapy. In the era of pre-perfusion therapy, the first trial by the Gutenberg metoprolol trial in 1983 found that beta blocker significantly decreased the deaths in comparing to placebo. Also, meta-analysis including more than 30 randomized controlled trials and more than 50,000 patients, and we found that beta blockers reduce all-cause mortality by 23%. Also, another meta-analysis including more than 18,000 patients, and we found that beta blockers decrease the overall mortality by 22, sudden cardiac death by 33, non-sudden cardiac death by 20%, and non-fatal MI by 20%. Also, the benefit is present whether the patient is diabetic or not diabetic, and the survival rate, those with receiving beta blocker and no diabetes. The era after reperfusion therapy differs somewhat, and you will see the results and the outcome of the results. This study published in the Lancet in 2001 in patients with ejection fraction post-MI and reduced the ejection fraction. The use of carvedilol decreased the all-cause mortality and the non-fatal MI. And recently, a study published in 2023 using the same molecule, carvedilol, and they found that the long-term carvedilol therapy in patients with STEMI with primary PCI might be beneficial for preventing cardiac-related events in those with mildly reduced ejection fraction. Also, another study, including more than 45,000 patients, and they found that the use of metoprolol, early use of metoprolol post-MI reduces the risk of reinfarction and ventricular fibrillation, but increased the risk of cardiogenic shock. This study published in 2017 and found that the use of intravenous beta blocker in patients admitted to the hospital with ST segment elevation increased mortality. Also, another study using the beta blocker in patients admitted to the CCU with STEMI before discharge, they found that the use of beta blockers decrease the all-cause mortality whatever the ejection fraction is below 40 or above 40, and whatever the patient undergone primary PCI for a single vessel or multi-vessel PCI. But there is a meta-analysis comparing the benefit of beta blocker post-MI in the era of pre-perfusion therapy versus the era of post-perfusion, post-revascularization therapy, and they concluded that the treatment of beta blocker reduced mortality in the pre-reperfusion but not in the perfusion area, and there is a reduction in short-term in myocardial infarction and angina, but increase the risk of heart failure, cardiogenic shock, and drug continuation. And concluded that the benefit for recurrent myocardial infarction and angina reduction by beta blockade in the reperfusion area appeared to be short-term, only 30 days. Recently, two studies presented in the European Society of Cardiology 2024. This study called Reduce Acute Myocardial Infarction and tested patients with ejection with post-MI, and the ejection fraction is preserved. Choose the patients with ejection fraction more than 50, and the primary point, the death or new myocardial infarction, and they found no significant difference for the use of beta blocker in those with preserved ejection fraction. No significant difference as regard the all-cause myocardial infarction and death, all death from any cause and the myocardial infarction, and they concluded that this trial suggested that treatment with beta blocker does not reduce the incidence of all-cause death or myocardial infarction in patients presenting with acute myocardial infarction and ejection fraction more than 50 treated by early invasive strategy. Another study published in the same conference called the ABIS trial. This trial addressed the point of discontinuation of beta blocker. Who went to discontinue beta blocker, and there is a difference for outcome for those who discontinue or those continue. And this trial, the patients discontinue beta blocker after 6 months of myocardial infarction. It is an inferiority trial, and concluded that interruption of beta blocker was not non-inferior to strategy of beta blocker continuation as regarded the primary endpoint, whether death, myocardial infarction, and stroke. Also, the quality of life, no significant difference. One of the argue that the beta blockers may reduce the quality of life, and so we have to discontinue beta blocker. They found that no difference in the quality of life, and at the same time, no difference in the primary outcome for those who discontinue or those continue. And finally, the recent guidelines of recommendation, intravenous beta blocker, preferably metoprolol, should be considered at the time of presentation for patients undergoing primary PCI, provided that systolic blood pressure is 120 and no contraindication. Beta blocker recommended class 1 for those with ejection fraction less than 40, but routine use of beta blocker for all cause acute coronary syndrome, regardless the ejection, should be considered. Finally, this is a final recommendation, American and European. We can use the beta blocker in patients with STEMI undergoing primary PCI. This is class 2A, not class 1. And for rate control, class and for atrial fibrillation and the VTAC, class 1 recommendation. Those with ejection fraction less than 40, class 1 recommendation. Those with heart failure, post-MI, class 1. However, those with preserved ejection fraction without left ventricular dysfunction or heart failure, this is class 2. For how long? For up to 1 year only, and can be extended to 3 years. And thank you.
Thank you very much, Dr. Tariq, for this excellent presentation. طبعا دكتور طارق من الناس اللي هم قريبين من قلبي جدا، وانا يعني احنا دايما سعداء بوجودك معانا في المؤتمرات يا دكتور طارق. انا بس يعني هايلايت بس بوينت معينه، عشان هو الهارت فيلير ويز بريزيرفد ايجكشن فراكشن الناس لازم يبقوا فاهمين ان هو في a lot of comorbidities مع الهارت فيلير ويز بريزيرفد ايجكشن فراكشن، ما هواش تايتل لوحده. احنا دايما بنتكلم على الدراج تريتمنت وبنتكلم على الاس جي ال 2 انهبيتورز والدايريتكس، انما we have to treat الكوموربيديز as well مع ده. من ضمن الكوموربيديز اللي موجوده ويبقى البيتا بلوكر هنا is a class 1 indication هو الاسكيميك هارت ديزيز والاتريال فابريليشن. يعني الاتريال فابريليشن مع الهيف بيف، الاسكيميك هارت ديزيز مع الهيف بيف لازم نستعمل فيها بيتا بلوكر، عشان ما ناخدوش ان الهيف بيف ما هواش بيتحسن. لو خدنا الهيف بيف بس لوحده ممكن ما يبقاش البيتا بلوكر ليه افكت، انما the presence of other comorbidities البيتا بلوكر هنا بتبقى essential زي ما قلت الاسكيميك هارت ديزيز والاتريال فابريليشن. دكتور ايمن اتفضل.
اولا اشكر حضرتك دكتور طارق على البرزنتيشن يعني الابديت للداتا. وبس انا عايز طبعا الجايد لاينز محترمه ولازم تبقى دايما تحت عينينا. اولا ملحوظ ان هو في اسوأ احواله فهو 2A should be considered، ده اقل ريتنج لو في حاجات كلاس 1. انما مش عاوزين ننسى ان في حاجات very well established ان sympathetic activity is risk determinant almost in all cardiac disease، مش بس الهارت فيلير، في الاسكيميك هارت ديزيز، البوست انفارشن، سواء ده كان اسيست بالسيجنال افريجنج زمان او بالهولتر او بحاجات كتيره. المير هارت ريت انكريز از ريسك فاكتور حتى في الهايبرتنشن. وامبارح اتعرض سلايد موجوده من زمان كانت اليوروبيان سوسايتي اوف هايبرتنشن اوف كارديولوجي كانوا يعني عرضوها ان الهايبرتنسيف بيشنت with uncontrolled hypertension but with a bradycardic site have better long-term prognosis than those with controlled blood pressure but with more tachycardic heart rate. اللي عايز اوصل له مش بقول ان احنا هنسيب الناس ضغطهم عالي، انما المسج we should not rush into degrading او excluding beta blocker in cardiac disease in general especially infarction، لان عندنا داتا راسخه sympathetic activity is a risk determinant independent risk determinant whatever احنا قيمناها ازاي.
هو عايز بس انوه على نقطه ان هو استخدام البيتا بلوكر بوست MI with preserved ejection fraction هم حطوه يعني ما عندوش هارت فيلير ولا reduced ejection fraction. كلاس 2A ملهو as a prognostic factor يعني for prognosis. ادي هو الستاديز كلها قالت شورت تيرم بنفيت، يعني 1 year up to 1 year after 1 year البنفيت for prognosis as regard mortality او hospitalization for heart failure is not recommended. ولكن if there is a compelling indication for the use of beta blocker زي لو في evidence of tachycardia او في evidence of increased sympathetic drive او arrhythmia we have to continue with beta blocker.
Thank you very much, Professor Tariq, for this elegant and coverable presentation. For the sake of time, we will now move. Thank you very much. We will now move to one of the important topics also, and we are really fortunate that we are practicing medicine in the era of SGLT2 inhibitors. And the topic today is where do we stand with GLT2 post-MI? Also another important topic by Professor Hussam Hassan, Professor of Cardiology at Sute University. Please, Professor.
شكرا دكتور سيد. طبعا انا سعيد بوجودي في الاقصر زي كل سنه، وبشكر دكتور عادل على الدعوه. هي البرزنتيشن على subject استخدام ال SGLT2 inhibitors post myocardial infarction. When you look to the spectrum of heart failure, we'll find that on the right side, the extreme, the heart failure presenting patients, we have a lot of studies regarding the use of SGLT2 inhibitors in patients with symptomatic heart failure, whether heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. We have DELIVER, DAPA heart failure, Emperor preserved, Emperor reduced, and even in patients with acute heart failure or worsening of heart failure, we have studies regarding the use even of this group of drugs in hospital in patients with heart failure. Slowest study, IMPULSE study, DAPA ACT heart failure, TIMI 68. On the other extreme, we have a lot of studies. These were the initial studies of this group regarding the use of SGLT2 inhibitors in patients at risk of heart failure, patients with risk factors for heart failure like hypertension, diabetes, CKD, obesity. We have a lot of studies, as you see, but we are lacking studies regarding the use of this group of drugs in patients with acute myocardial infarction. Regarding ischemic heart disease, we have subgroups in these studies where patients with manifest heart failure, reduced or preserved ejection fraction, with proved efficacy of this group in patients with ischemic cardiomyopathy. And in patients with diabetes and ischemic heart disease, we have an evidence of proven benefit in this subgroup of patients, but we don't have evidence in patients in the setting of acute myocardial infarction. With advancement of therapy in patients with acute myocardial infarction, the coronary deaths are reduced by half from 1980 to 2000. With the introduction of primary PCI, high-intensity statin use, ACE inhibitors, reduction of mortality to the half. This was on the expense of increased prevalence of heart failure in these patients. We have tripling of the prevalence of heart failure, and the number of patients with heart failure is much increased because these patients survive the acute attack of heart failure, but they survive with cardiomyopathy and with recurrent heart failure. And so the costs of heart failure treatment are expected to increase in the next years. The problem of heart failure is that heart failure mortality in 2021 is more than mortality, for example, in 1999. Recent data suggests a plateau or reversals after long-standing declines in cardiovascular mortality, particularly heart failure-related mortality. There was a reduction in mortality from 1999 to 2011, and then the mortality began to increase again in patients with heart failure or to be plateaued in several studies. Urgent need to prioritize prevention, early detection, quadruple guideline-mediated therapies, stronger focus on heart failure-related education, strengthening of remote patient care, and implementation of existing interventional therapies, and the continued need for innovation. We need innovation, more and more innovation regarding the prevention and treatment of patients with heart failure. This slide shows that patients post-myocardial infarction with heart failure, there is plateau in the mortality in these patients, as you see in this study. There is a proven time-dependent treatments in high-risk myocardial infarction and heart failure with a lot of drugs introduced in therapy of heart failure, like immediate reperfusion for STEMI by primary PCI, the use of ACE inhibitors in the first 24 hours, the use of mineralocorticoid antagonists in the first 7 days, the use of beta blockers, as Dr. Tariq showed us, and patients with acute myocardial infarction and heart failure in the first 24 hours, it is better to avoid, and then to start beta blockers later on after stabilization and the up titration of the doses. These practices much improved the outcomes of patients with heart failure, but these are still not enough. Impact myocardial infarction is a study that was recently presented that showed the efficacy of this group in patients in acute myocardial infarction. The patients with STEMI or non-STEMI at high risk of heart failure were randomized to either empagliflozin 10 milligrams versus placebo. The design of the study was to collect at least 532 primary endpoint events to achieve the target of this study to end the study. The primary endpoint of this study was either first heart failure hospitalization or all-cause mortality. Impact MI was a streamlined trial, use of inclusion and exclusion criteria readily available for routine care, no specific inclusion and exclusion criteria, mainly remote follow-up visits, streamlined data collection, including focused collection of safety information, and blinded investigator review instead of central adjudication, additionally supported by structured data collection. The primary endpoints showed no statistical difference between the two groups. There was a trend towards a 10% relative lower risk with empagliflozin, but this was not significant. And the events reported in this study, half of these events, 48% were heart failure hospitalization and 52% were deaths. When you look to the components of the primary endpoint, time to all-cause mortality was not significantly different at all. The main benefit with the use of SGLT2 inhibitors in patients with acute myocardial infarction was the reduction of time to first heart failure hospitalization. And this is logic. It's a drug for heart failure. 33% relative risk reduction of time to first hospitalization for heart failure, and the total number of heart failure hospitalizations was also reduced by about 33%, as you see in this slide. Effect of empagliflozin on total heart failure adverse events was also significantly better with empagliflozin. As you see, it was about 37% mean cumulative function. And when you look to total number of adverse heart failure or all-cause mortality, it was significantly lower by 31% with empagliflozin. Regarding the safety, there was no significant difference in safety between the two groups, and safety here is important. Unlike the other reports of empagliflozin in heart failure, because this is a setting of acute myocardial infarction where the patients are hemodynamically unstable, and we are afraid of hemodynamic instability that could be caused by SGLT2 inhibitors or acute kidney injury that is higher in this group of patients. Actually, the study showed that there was no significant difference at all between empagliflozin and the placebo, especially in patients, especially regarding the acute kidney injury, as you see. The different studies previously published about SGLT2 inhibitor heart failure, of course, show the benefit of the use of this group in reduction of prevention of heart failure and in treatment of heart failure. So the drug will differ between patients with a compelling indication of SGLT2 inhibitor like diabetes or heart failure from those without diabetes and heart failure and acute myocardial infarction. Patients with an existing indication, it is safe to start during acute myocardial infarction settings. Benefits of primary indication and heart failure benefits are proven. The subgroup analysis in this study showed that both groups, patients with a compelling indication like diabetes, CKD, should benefit with the use of SGLT2 inhibitors, and patients with no indication, no diabetes, no CKD, should also a significant reduction in the heart failure time to first hospitalization, as you see here, with a relative risk reduction of 33%. Time to first to heart failure hospitalization. When we look here, the lower the more the congestion and the lower the ejection fraction, the better the benefit with SGLT2 inhibitors. When we look to the patient population included in this study, STEMI patients actually were about 3/4 of the patients. This is unlike the normal distribution of the acute coronary syndromes. As you know, acute coronary syndrome, 3/4 of patients are unstable in STEMI and 1/4 is STEMI. The patients included in this study, 3/4 were STEMI patients. So this is a high-risk population include in this study, and 3 vessel disease were about 1/3 of the patients, as you see. Patients with ejection fraction less than 45% were about 78%. Prior myocardial infarction 13%, diabetes 1/3 of the patients, as you see here in this patient population. The benefit in STEMI in non-ST segment elevation myocardial infarction was much obvious than patients with ST elevation myocardial infarction, and this is another important finding in subgroup analysis. So in conclusion, the totality of evidence suggests that the benefits of SGLT2 inhibitors in heart failure risk reduction in patients post-myocardial infarction without prior heart failure, consistent with the benefit demonstrated in other trials of adjacent patient population. Patients with NSTEMI and low ejection fraction, low left ventricular ejection fraction are at particularly higher risk, and those patients get more benefit with the use of SGLT2 inhibitors, can be safely initiated in those with other indications for SGLT2 inhibitors. And still, they are beneficial in those without a compelling indication for SGLT2 inhibitors. Thank you very much.
Thank you, Professor Hussam. Actually, it was an elegant presentation. Before open the floor for discussion and for the dearest chairperson and panelists, I'd like to ask you about practically when to start the SGLT2, especially in the context of NSTEMI versus STEMI during the hospitalization, early in the hospitalization, late in hospitalization, or after discharge.
Okay, in practice, still we don't have this indication in post-myocardial infarction. The use of SGLT2 inhibitors post-myocardial infarction is not in the guidelines till now. We use it just in patients with diabetes and patients with heart failure, okay? Of course, the use of this group of drugs in patients with heart failure depends on the patient hemodynamics, the volumetric condition of the patient. Euvolemic patients can be safely given SGLT2 inhibitors. Dr. Abdullah is
تفضل دكتور عبد الله. نورنا يا دكتور عبد الله مشرف.
Thank you very much. Excellent topics. To be practical, you know, this is patient come to me with MI. Patient got diabetes. Obviously, I will start patient on the SGLT2 inhibitors.
Of course.
Patient with heart failure, I'll start with them.
Okay.
So, I mean, in other situation, like without diabetes, without heart failure, it's safe to use SGLT2.
It's safe, yes, and beneficial according to this study.
I think that's the message.
Yeah.
For me.
احنا بنخاف بس من العيانين اللي هم عندهم ار في انفاركشن في ان احنا نبدا SGLT2 inhibitors immediately، لان هم دول اللي بيبقوا تقريبا عندهم مشكله في هايبوتنشن، ان احنا محتاجين نديهم فوليوم لودنج في الاول، فهم دول يمكن اللي بنأخر شويه استخدام SGLT2 inhibitors. اذروايز اعتقد مفيش مشكله في استخدامهم يعني.
هو في another study حضرتك ذكرت الامباكت ام اي، في another study ده بقى ام اي وبرضه published 2024 وفيلد في البرايمري اند بوينتس اللي هو
وهي دي فيلد في البرايمري اند بوينت. بس هي دي في البرايمري اند بوينت اللي هي كانت time to first heart failure hospitalization، هي اللي كانت فعلا significantly better، لكن البرايمري اند بوينت اللي هي كومباينيشن ما بينها وما بين التوتال مورتاليتي هي فيل.
حتى الدابا ام اي ما فصلتش الهارت فيلير هوسبيتاليزيشن لوحده، قالت فيل، وقالت ان في امبروفمنت في الميتابوليك. فانا رايي وده اللي برضه في الريكومنديشن ان روتين يوز اوف SGLT2 inhibitors post MI without heart failure is not recommended unless the patient is diabetic or CKD.
هو الاستادي فعلا هو المورتاليتي، ما فيش مورتاليتي بينيفيت في العيانين اللي هم ما هماش هارت فيلير، لكن هي في ريدكشن اوف اوكرنس اوف هارت فيلير في العيانين دول ليتر اون يعني. لكن لحد دلوقتي فعلا ما فيش ريكومنديشن في الروتين يوز في البوست مايوكاردال انفاركشن.
Thank you very much دكتور حسام على this nice presentation and we have to move for the sake of time.
شكرا.